So let's get started with tonight's program. You are here for the ins and outs of insurance and specialty pharmacy. I like to say specialty pharmacy and insurance, but I got shot down on this, so we're saying it the other way tonight, okay? All right. It's shared decision making. It's learning about the ins and outs of, what you have and how you can access your insurance needs and your medication needs. And, if you're being turned down for medication, and what are your options? Or if you have to change to another medication, what are your options? Medically speaking, as well as insurance questions that you might have. So Dr. Gary Owens has spoken for us many times, but I'll get to that in a minute. All right, so you all know me already. I hate showing the slide, but I have to, all right? The main thing is, though, we have to thank SANDOZ. All right, SANDOZ is our supporter for tonight's program, and so we all want to give them a virtual thank you. Okay, next. So next, we have Dr. Gary Owens. And Dr. Gary Owens, he's going to talk about himself in a few minutes. But he's a former primary care physician and a former VP of a medical health care plan. And again, he will speak with you about that in a few minutes, and he'll talk to you all about this program. All right, thank you. Dr. Owens, take it away.
Well, thank you very much, Stuart, for that kind introduction. And as we move ahead, I'll introduce myself a bit more. As Stuart said, I spent 14 years as a primary care physician in northern Delaware. I had my first exposure to MS there with a few patients in my practice. I will point out I'm not a neurologist and not a regular treater of MS, but as you'll see in a moment, I have a keen interest in that. After leaving primary care practice and actually the world of academia, I spent the next 2 decades plus as a medical director and VP of medical management at a Blues plan. And I not only managed our medical benefits, but I also ran our pharmacy benefit management group and oversaw a number of other activities. And after I retired from there, I've served as a consultant to a number of healthcare companies, including those people who develop MS treatments, as well as some organizations that are developing MS diagnostics and prognostic testing. But that's a tale for another day. I do, as you probably guessed by now, have a professional focus on MS. I was back in either 1991 or 1992, the time blurs. I was chair of our Pharmacy and Therapeutics Committee when this very revolutionary treatment, one of the first biologics came along, that is beta interferon for the treatment of MS. And I was charged with the evaluation of that relatively new and extremely innovative product. And I led a team of physicians and pharmacists to evaluate that, and have really been engaged in evaluating MS drugs, MS treatments, MS clinical trials since then. On a personal note, even more germane, is that I actually have 2 close family members with MS, a niece on my sister's line of the family has had MS for almost 3 decades now. And I have a son who's in his 40s now, who was diagnosed with MS in his mid 30s. And so I'm not only privileged to talk to groups like this, but also talk to academic groups, payer groups, and have joined a number of my colleagues in doing some original research, mostly around the economics of MS and the economics of treating MS. So that's a nice lead in to what I'm going to talk about tonight. I really do believe that insurance in general is probably one of the more poorly understood things that all of us have, whether it be property and casualty insurance, life insurance, and of course what we're going to focus on tonight, health insurance. And so I really want to start, and that's why, as Stuart said, is it specialty pharmacy and insurance, or insurance and specialty pharmacy? I tend to look at it in the world of insurance first, because if you don't understand what you're dealing with there, you really can't understand what flows downstream from that. I'm going to talk a good bit about specialty pharmacy, why we have specialty pharmacies, what specialty pharmacies do and what they don't do. I kind of put that term friend or foe, but I'm not sure that I'll answer that question entirely. I think a lot of that depends on perspective. But then I really want to close with some advice on managing insurance coverage, talking to your doctor about that insurance coverage and what you know about it, and leading into shared decision making. Because as you heard from Stuart, you need to understand how to get your medications, the steps you need to go through to get those medications. What if I can't get the medication I want? What if I can't afford the medication that I need? And how can I work within that time frame and within those parameters? So let's talk a little bit about navigating the complex world of health insurance. Health insurance has terms that are unique to it. And as we'll see as we move forward on the next slide, there are a number of terms that seem to be basic, and they're certainly common dictionary words, but in the world of health insurance, they have different meanings. And we're going to walk you through what each of these terms means and why they're important to you and why you need to understand them in the context of health insurance. So let's start with what is a payer. I mean, we all pay for things. We pay for things when we go shopping. We pay for things online. We pay for things in informal ways. But the definition of a payer in the health insurance world is really very formalized. It's an organization, whether it's an insurance company, a pharmacy benefit manager, or even the federal government that takes care of financing and operationalizing healthcare. And what I mean by operationalizing, that is seeing that you get enrolled in a health plan, that your claims are paid, that you understand your health plan, you understand your benefits. And so who are the payers in the United States? Well, ultimately, you and I are, and I'll explain that in just a minute. But the biggest payer in the United States are federal and state governments through federal programs like Medicare, federal and joint state programs like Medicaid, and of course, federal programs like the VA benefits and the Department of Defense benefits. Second biggest payer in the US are those for whom we work, our employers. The US is very unique in that of the major wealthy countries. If you look at Europe and most other major wealthy countries, of which the US is privileged to be one, most healthcare is funded through public funding, but almost half of our healthcare, about 45%, is funded through employers, through employer benefit plans, who in turn engage private health plans as the payer. And then you as private citizens, me as a private citizen, pay for about 10% of healthcare, either with our shared costs through our insurance plan or because we have bought a health insurance plan on the open market, mostly now those plans that were implemented under the Affordable Care Act. But what do these all have in common? Ultimately, we, that is you, me, Stuart, and everybody on the program tonight, pays for everything through taxes, premiums, or employer deductions from your paycheck or employer contributions on your behalf. So the next term I want to talk about is a benefit plan. We all know the word benefit, but in terms of health insurance, the benefit is literally a formal contract. And that contract is between the health plan, that is the payer, and the individual or group, in many cases, the employer. And that formal contract spells out the terms and conditions of what's covered. And all of you, if you look over on the right-hand side, will probably have a card that looks something like this. If you're a Medicare beneficiary, you'll have a Medicare card. If you're insured by one of the Blues, you'll have a card with the Cross and Shield logos. If you're insured by a private health plan or a publicly traded health plan, you'll have something that may say Aetna or United or Priority or Kaiser, something of that. That contract, again, spells out the terms and conditions of your coverage. Sometimes it even has limits on some things that you're covered for. Again, if you're a Medicare beneficiary, you know you have limited coverage for such things as rehabilitation services, some durable medical equipment, things like orthotics and prosthetics under Medicare can only be replaced in a certain period of time. And of course, the other big condition of the contract is that you have cost sharing, and those cost sharing are in terms of things like copayments, co-insurance, deductibles, and benefit maximums, all of which I'm going to talk about in just a moment. But in essence, that contract points out that there are federally and legally mandated benefits such as hospital coverage, drug coverage, obstetrical coverage, mental health coverage, rehabilitation services, and many others that are basically called the 10 essential health benefits. So that's enough about contracts. So when we talk about benefit plans, we're really talking about contracts. And as we move forward now, I'm going to talk to you about some of those terms that I brought up in the other slide. So let's talk about what cost sharing is in just a bit more detail, and hopefully without boring you to tears. First of all, a deductible, that's what you pay before your insurance benefit starts. And even in Medicare, you have a deductible. Medicare has a deductible on the drug side. It also has a deductible on the hospital side, which means that money must come from you, the beneficiary, before any insurance coverage starts. Then once your insurance coverage starts, you still may have cost sharing. One of those forms of cost sharing is what's called a copayment, and that's a fixed amount. So a copayment says you pay X dollars towards a service. So if it's a drug, you may be paying $50 or $100 towards that service. If it's your specialist office visit, you may be paying $25, $50, or even $100 towards that. It's always fixed, and that's what a copayment means. Co-insurance is quite the same in many ways, but the amount you pay is variable because you're paying a percentage of the cost of the service. So if you have a drug that costs $100 and your co-insurance is 20%, you're paying $20. If you have a hospitalization that costs $10,000 and your co-insurance is 10%, you're paying 10% of that. And then, of course, what we also need to understand is in most insurance plans, including even Medicare, once you reach your out-of-pocket maximum, then coverage becomes 100%. But then there's also, in some areas, a benefit maximum, which means it's the maximum allowed by your insurance towards a service. And after you've reached that benefit maximum, you pay the rest. And even in Medicare, that happens. You can use up your lifetime days and then have to pay for additional care. Other terms that I want to bring up, and this becomes very important as we talk about pharmacy, is the concept of a formulary. And a formulary is nothing more than a list of medications, but it's a list of medications that are supported by evidence, typically by pharmacists and physicians who are on the committees that make the formulary. And they basically have three versions of formularies. The first version of the formulary is an open formulary, which means that virtually all drugs are covered, except those that are specifically excluded, maybe lifestyle drugs or cosmetic drugs, but they're covered at different levels depending on their position on the formulary. There's an open formulary with exclusions, which sounds like an oxymoron because how can it be open and have exclusions? Well, the reality is it covers most drugs at different out-of-pocket costs, but then there's a small number of drugs, although we'll admit in 2022 for some formularies that number of exclusion has grown to hundreds, and those excluded drugs are not covered or only covered by exception. And then there's a closed formulary, which basically means there's a finite list of drugs. Those drugs are covered and everything else is not covered. Now, the good news is the number of closed formularies out there is diminishingly small, but you will encounter them in some Medicare Part D plans. Another concept in pharmacy that we need to understand is a concept called step therapy, and you may have heard of this because step therapy basically says that you need to have tried either a clinically proven, meaning likely more efficacious or safer treatment, or if there are a number of therapeutic options for your disease, whether it be MS or something else, and some of those medications are more cost effective than others. That means they're similar or identical in safety and efficacy, but some are less expensive. You have to try those first. And so in step therapy, basically, there are multiple ways that can be implemented. The simplest step therapy is if there are generics in a category, you may have to try a generic drug before you can get coverage for a branded drug. In other cases, there are preferred branded drugs, meaning the P&T committee that I talked about earlier and the formulary that I talked about earlier has created a list of preferred drugs for which you have a lower out-of-pocket cost, and therefore you have to step through one of those before you can get a non-preferred branded drug. And then finally, there are guideline-based step therapies, which says if there is a logical guideline out there, there aren't so many in MS. Things like diabetes and heart failure have much more rigid guidelines, and the guidelines tend to determine what drugs should be used first, second, and third in line. So step therapy can also be guideline-based, but that's generally not applicable to MS drugs. And finally, the last term I want to talk about is a term I'm sure every one of you has experienced in your life, because if you are taking an MS drug or have had to have an advanced imaging study such as an MRI scan, you've probably experienced a prior authorization. But in the context of your drug benefit, a prior authorization is implemented by the health plan to try to ensure that the drugs are administered for the right patient and administered for the right indication, in essence, administered as they're intended. And it's really a goal. It's not meant to be pejorative, but it's meant to ensure that the medication that you get, that I get, that our family members get are safe, effective, and hopefully provide the greatest value both clinically and economically. But it does require some work. It requires your prescriber, your physician, your neurologist, your MS specialist, your primary care physician to do some paperwork, to submit the pre-approval, and to get the payer's approval before ultimately prescribing, or ultimately before the payer will pay for the drug. And so prior authorizations have grown in number. They've sometimes grown in complexity, and they've certainly increased the time burden on all physicians. And as we move forward, what I'm going to point out now, as we move into specialty pharmacy, is you might ask the question, well, gee, MS is a lifelong condition. It's a chronic debilitating condition. I need medication for that. No one doubts that. But what we do know is in specialty pharmacy, it's one of the higher cost areas of specialty pharmacy, up there with oncology, hepatitis C, inflammatory diseases like psoriasis, rheumatoid arthritis, inflammatory bowel disease. And because of the cost of these medicines and because of the complexity of these medicines, they often are managed by specialty pharmacies, managed with prior authorizations. And I guess if there's one thing as an MS patient, you're not being singled out, because patients with diseases in all of these categories commonly and frequently experience prior authorizations and experience interventions by specialty pharmacies in order to get their medications. So as we move along into the next segment of the presentation, I'm going to talk a bit about specialty pharmacy. And again, I think that friend or foe is a bit more of a rhetorical question. I won't answer that question. Like many issues, it all depends on your perspective. And I will say right offhand, specialty pharmacies serve many beneficial aspects, but at the same time, they do increase a bit of complexity, which can be frustrating at times. So let's take a look at some of the issues around specialty pharmacy. Pardon me while I take that so I don't cough at you. So what is a specialty pharmacy? Well, a specialty pharmacy is a drug distributor, really literally mostly a remote pharmacy that focuses on drugs that are high cost, high touch, which means they may have specific storage requirements, distribution requirements. Think about the COVID-19 vaccine when it came out. It had very rigid storage and transmission requirements, had to be a complex cold chain of storage. And usually these drugs are reserved for patients with complex disease states such as multiple sclerosis. So in essence, these specialty drugs are those high-cost prescription medication used to treat those complex conditions you saw on the previous slide. So why do we even have these specialty pharmacies to begin with? Well, now a couple of decades ago, we recognized that many of these new and emerging specialty drugs, remember I was involved in evaluating the first biologic for MS, beta interferon, followed closely behind by one of the first biologics for cancer patients to treat low white blood cell counts in them, a drug called filgrastim, but I digress a bit. But they were created because these drugs needed special handling, and this special handling, as well as the cost of these drugs, were often outside of the scope and willingness of local pharmacies to manage these drugs. And because of the rise in specialty pharmacies, and because these drugs are often complex, expensive, they create expensive inventory issues for pharmacy, you can't take most of your prescriptions for MS to your local drugstore, even if it's a Walgreens or a CVS or one of the big national chains. Now, there's some exceptions there because those particular entities that I just mentioned have their own specialty pharmacies. But in general, you need to go to a specialty pharmacy, often one recommended or required by your payer. Remember, your payer in this case is your insurance carrier or public funding programs like Medicare or Medicaid. And specialty pharmacies have a lot of behind the scenes activities that you need to understand just a little bit. Basically, what I'm going to do in the next few slides is open the hood a bit of what's inside of a specialty pharmacy and how they perform. And so before I do that, I will point out, why insurance companies use specialty pharmacies besides the obvious things I've talked about. And what we've really seen is the enormous growth in specialty pharmacy just in the last decade. If you look in just the last decade, and that number in 2022 actually has reached 50%, the proportion of drugs on a cost basis that are considered specialty pharmacy drugs has gone from about 17.5% up to 42% in 2020. That's that decade of growth, and now it's over 50%. MS drugs are expensive, and MS drugs often have interesting or different modes of administration, injectable modes of administration, monitoring after you take the drug in some cases, infusion in some cases, drugs that are given several weeks or months apart, and of course some are simple oral regimens, but those regimens can be complex. So that's the reason insurance companies have turned to specialty pharmacies to assist. So as we'll see as we move along here, there are a number of things that go on in a specialty pharmacy before you get your prescription. First of all, there's universally going to be prior authorization. What does that mean? That means your doctor is going to need to document the medical necessity of the drug, and that can be done by a phone call. It can be done online. In fact, most specialty pharmacies now have and encourage online completion, of the prior authorization forms. But it also means that someone at the payer needs to evaluate that request against medical evidence and evidence-based criteria. Remember, that prior authorization, although some of that even now is being automated. So if your doctor answers the question that meet those evidence-based criteria, they'll get an answer back, just like when you and I put our credit card information and our card number matches our billing address and our name, and you get instant approval. But in some cases, if there's incomplete information or the information initially submitted doesn't meet those evidence-based criteria, your physician may need to supply more information, and there may be some back and forth between the physician and the specialty pharmacy. And what does that cause for you? That causes what feels like sometimes an interminable delay. The other thing that goes on at specialty pharmacies is formularies come into play, because specialty pharmacies do what's called a benefit check. Remember that term from way back? It's what the contract looks like between you and your health insurance carrier. And basically, they want to make sure that the drug that you have requested not only meets prior authorization criteria, but is it a preferred drug by your plan? Is it on the formulary? Is it not on the formulary? And if it's not on the formulary, can your physician justify a need for that drug versus a formulary drug? And as you know, sometimes those discussions can be prolonged and a bit complex. And so why should you care about a formulary? A formulary is a list of drugs. Why do I care about a list of drugs? And I think the left-hand slide explains it all, because as the tier level of drugs go up from generic drugs to brand preferred, and we're now talking about pills for commonplace diseases like high blood pressure, diabetes, heart conditions, bone diseases, that sort of thing, the cost goes up. And when you reach specialty level of drugs, the cost goes up enormously. And so you need to care about a formulary, because if your drug is in a specialty tier or in a non-preferred tier, you may be paying a lot more out of pocket than an alternative treatment sometimes. And yes, there are generics now in MS drugs. There are generics for things like fingolimod, which is a generic drug. Tecfidera is a generic drug known as dimethyl fumarate. And so we're seeing more and more of those. And of course, an injectable generic of Copaxone is glatiramer. So sometimes generics come into play. And also, if your drug's not on formularies, I indicated on the previous slide, there may be a little bit more back and forth. And most importantly to you, if your drug isn't on formulary and your doctor feels there's a reasonable and acceptable alternative, he or she may wish to provide that for you, because number one, it's an easier path to get it covered, and number two, may actually be less costly for you. And so what do you need to expect in MS treatments and prior authorization at the specialty pharmacy? Unfortunately, the bottom half of the slide is more the usual case, but there is such a thing as a soft prior authorization where your doctor prescribes a drug. The specialty pharmacy confirms that your prescriber is indeed an appropriate specialist, a neurologist or an MS specialist, and that the indication for the drug is your type of MS, say relapsing remitting MS in most cases, and the drug gets approved. And that's in essence what we know as a soft PA. Unfortunately, the hard PA, and I think it's an interesting choice of terms, because hard can mean one thing, difficult. Hard can also mean that firm, as in the criteria are firm. In that case, it's the one I've already described. The doctor prescribes the drug, they fill out the criteria, the prescription and the patient criteria must match, and the product gets improved. And as I pointed out, and as you can see on the bottom of the slide, most MS drugs do require this hard PA, which sometimes can be time consuming and even a bit frustrating for you and your physician if it doesn't go smoothly. The good news is about 90+% of these do go smoothly, but that 10% is a big and looming 10%, and can certainly be difficult if you're in that small group of people. Remember I mentioned step therapy? Why should you care about step therapy? Well, the drug your doctor prescribed may actually be one that requires a step. It may require a step through a preferred drug, or nowadays could even require a step through a generic. And if you haven't met that step, again, then it's going to trigger a prior authorization in order for the doctor to explain. So even in step therapy, where there's something that you have to try before, if you haven't met that step, your doctor is going to need to ask for an exception. Or if you have met that step and the doctor hasn't documented it well in the prior authorization, that'll have to be done now. So sometimes it's fairly difficult to get those exceptions to step therapy. So you do need to care both about prior authorization, step therapy, not that formularies and other things aren't equally as important. And so what I've been trying to stress here is taking time to get through this process is frustrating, and it can seem very, very difficult. But there are some rules of thumb. If the prior authorization is complete, there's no missing information, and everything matches criteria, payers are required by regulation to turn those requests around in 72 hours. So if everything goes smoothly, a payer has to turn that request around in 72 hours, and your specialty pharmacy gets the approval and can then proceed. But we're not done yet, but I'll get to that in a moment. Urgent requests, those are usually for things that are immediately life or limb threatening, or threatening to see a patient's health care go downhill quickly. For instance, a treatment with antibiotics for a severe infection, or treatment with a blood thinner when one has a severe blood clot, are often things that comprise urgent requests. But as I pointed out, incomplete requests by your doctor can take up to 30 days. And even once the specialty pharmacy gets that prescription and gets the prior authorization, even if everything goes smoothly and it gets to them in that 24 to 72 hours, they have another 24 to 48 hours to ship overnight. And overnight shipping used to mean overnight, but I think we all know in the current midst of the pandemic or the post-pandemic world, sometimes overnight shipping is no longer overnight. And one other thing, which is going to segue nicely into my next slide in just a moment, shipping doesn't happen until your member responsibility is met. So over on the right-hand side of the slide, I just put some of the big frustrations with prior authorizations done in a survey of physicians, which includes administrative burdens, delay of care, sometimes policies and formularies change, and of course reimbursement is still an issue. So with that, we can move forward and transition to some of those issues around what happens when prior authorizations don't work out so well. Well, first of all, you could get a prior authorization that's rejected. And the first thing you know, you do always have a right of appeal. Most of those appeal rights have multiple levels. So one of the first things your health plan is required to do is notify you in writing, and you can also call and be notified verbally if you get a verbal denial of why your request is being denied. They have to give you a medical rationale. If you decide to appeal, you and your private provider do need to collect evidence, and so you need to talk to your provider or your provider's representative. Often it can be a financial coordinator or a nurse. You need to ask for a formal appeal and then provide reasons to your insurer why they should approve it. Should they stick to their guns, you can appeal the decision to a second and even a third level. And in most states, the third level is with a non-involved, meaning they don't belong to the insurance company, or they're not your physician appeal body that often consists of what are called independent utilization reviewers, who are match specialties to the prescriber of your treatment. And so I'm going to sum this part up and then move into a little bit of reimbursement issues. Getting MS, as I've told you, is not like getting your standard medication. You are going to interact with a specialty pharmacy. At times, they can seem like your friend because everything works right. Maybe sometimes they feel like your foe because it's taking longer than you had hoped or expected. And there may be multiple points of contact. But what I also want to point out is we live in a world of finances and high-cost drugs when you're taking an MS drug. And there's some things I think you really need to know and understand. So let's talk about some new things in the world of cost sharing. And remember, we talked about co-payments. And so this next section, as we move on to the next slide, we'll begin to talk about two recent developments that you may all have encountered. The reality, I've made this very clear, so I won't spend a lot of time on this. MS drugs are high cost. You have a cost share. That cost share can sometimes be a burden to you, and sometimes that cost share can be a significant impediment to you getting a drug and can put a strain on your personal finances. And one of the things we know in a recent survey I saw conducted by a payer advocacy group, they really pointed out that almost half of MS patients need cost sharing assistance, which means, don't feel badly or feel embarrassed or feel, what's wrong here if you feel you can't afford your drug, because, you're not alone there. Virtually half of you have that, but you're not alone. Almost 60% of patients with rheumatoid arthritis have the same thing, and 60% of them have used cost sharing assistance, and more than half of those of you with MS. So, this is not something that's unique to MS. It's definitely something that's unique to patients who fit in those categories that I showed you way back. And it's just a way of life now that these drugs are expensive, and cost sharing becomes an essential part of what you need. And in another reality, and this was some data taken from a Kaiser Family Foundation, that the unintended consequences of this cost-sharing burden is just a bit over 1 in 4 patients have put off needed medical care because of that cost sharing, and 1 in 5 have put off filling a prescription. That's not limited to just MS drugs. That's all medical care and prescriptions across the board. But again, I put that in there to show you you're not alone if this puts stresses on you and you're worried about how am I going to get my medications. And so what I'm going to talk about now are 2 things. One is what's called a copayment accumulator, and the other is something called a copayment maximizer. And they're very important for you to understand because they can impact sometimes how you get your benefits. So on the first slide, and I'll apologize ahead of time that it's a little bit busy, but I need to just walk you through a bit of that slide. In a copayment accumulator program, basically what happens there is if you have to meet an out-of-pocket maximum or a deductible in a copayment accumulator program, the manufacturer's assistance that they provide you does not count towards that deductible or out-of-pocket maximum. So if you look in the purple in scenario A in the old world, if your manufacturer paid $6,000 in copay assistance and that met your deductible or out-of-pocket maximum, you didn't have to pay anything after that. In a hypothetical $24,000 drug that you can see across the top of this slide, the payer would be paying the remaining $18,000. However, in a copay accumulator program, remember that what the manufacturer pays, that $6,000, doesn't count towards your deductible or out-of-pocket max. So when you run out of assistance, you now have to pay that deductible. So now your out-of-pocket cost in that scenario goes from $0 to $2,000, and what the payer pays is $16,000. So in those places where there are copayment accumulator programs, you will be faced, if you run out of manufacturer assistance, with having to pay something out of pocket up to your deductible or benefit maximum. And so let's move on. These are growing in importance. As you can see now, almost 60% of payers have copayment accumulator programs in effect. So I dare say many of you have hit and run afoul of those programs. And I think if you look at the bottom half of this slide, over in the dark blue on the left-hand side, another third of payers expect to expand these programs over the next 6 to 12 months. Again, these are some data for the Kaiser Family Foundation. But wait, I feel like an infomercial here, like one of the shills for whatever product you're buying online, and they tell you, now that you're willing to pay $20 for this, I'm going to give you 2 of them for $20 plus free tickets to the Red Sox game. I digress a bit there. But copay maximizers really are the next step in the evolution from copay accumulator programs. And they were introduced to really maximize manufacturers' copay assistance programs before you or your payer has to pay anything. And so basically, in a maximizer program, they spread the manufacturer's benefit out over 12 months, and they have to use up all of that program before your contributions or the payer's contributions begin. So I'm going to again apologize for another busy slide that's going to look remarkably similar to the one I just showed you. But in a maximizer program, we have that same $24,000 drug. And again, in this scenario where there wasn't a maximizer program, the copay assistance from the manufacturer maxed out at $6,000 because that was your maximum out-of-pocket cost, and you basically didn't have to pay anything. But let's, in this case, assume that the maximum manufacturer assistance, as you can see in the bottom of the slide, is $16,000. So what will happen is they will take 1/12 of that $16,000 throughout the year and make you pay your relative proportion in that maximizer program. So essentially you and the manufacturer are paying for all but $6,000 of that $24,000 drug. So it's not as prevalent as the copayment accumulator programs, but in some very aggressive benefit packages, sometimes driven by employers who are ultimately paying the bill for yours, mine, and everyone else's drugs, they've pushed for these copayment maximizer programs to be implemented. So as we transition into my last portion of the talk, what I want to point out is really three things. Number one, you're not alone in needing financial assistance and understanding financial assistance. Number two, you're not alone in knowing that sometimes drugs can be too expensive, and therefore you may need to look at alternative therapies or alternative treatment options. And it brings us to the concept of what I'd like to call I don't call it shared decision making. I didn't make up the term, but I think it's a very appropriate term, because in shared decision making, you and your doctor share information not only about your clinical condition and the treatment options, but share decisions about finances and financial toxicity potentially of the medication you're taking. And with that shared decision making, you jointly make a decision about what to do next and how to proceed. So the next handful of slides, as we come down the home stretch of this presentation, I'll talk a little bit about shared decision making, because it really becomes, I think, an integral part of what you and your provider of care need to do. So the first slide in this presentation, I'll talk a little bit about what is shared decision making. Well, it really occurs when your healthcare provider, your doctor, and you, the patient, work together to make the best decision that takes into account, from the doctor's side, evidence-based information, the provider's knowledge, your values, and preferences. And sometimes those preferences can be mode of administration driven, they can be convenience of dosing driven, but they can be financially driven as well, to tie it into what I talked to you before about how out-of-pocket costs are still a burden. And so in an ideal shared decision-making program, we have come up with this acronym called the SHARE approach, and it's something that I encourage providers when I talk to them to begin to do. So this is more directed at physicians, but it's something, if you begin to see this type of process going on between you and your doctor, I think it's no longer, I am the doctor and I'm telling you what you need to do, and I'm not inviting a lot of feedback. So it's a 5-step process where doctors need to seek and encourage patient participation in those decisions, to present them with multiple options, to kind of understand your values, your preferences, your perspectives, and you reach a joint decision, and then maybe even at subsequent visits continue to evaluate that decision to make sure it's the right decision. We all know in life's decisions, we make those decisions, and sometimes when we reassess them, we wish we could take them back or modify them. So the SHARE approach is just really an acronym for the ideal process that ought to be happening out there. What I want to encourage you to do as patients is don't be afraid to ask questions, and whether it's of your doctor, of their physician's assistant, of the nurse, or even in the patient assistants that are in there who may be financial assistants or coverage assistants, communicate your preferences, your choices. You know, don't be afraid to communicate those choices, and recognize that we as physicians know that there's a lot of art behind the science of medicine, and many of the decisions we make for our patients we think are the right and the best decisions. But because of that uncertainty, we need your feedback to make the best decision for you. Personalized care is what it really comes down to, but personalized care within that give and take, the back and forth between you and your caregiver. And so some things to ask as I really get down to the final few moments of my presentation. Ask your doctor, what are my treatment options at this stage of my disease? Do I have more than one treatment option? May I discuss with you or somebody in your office what my insurance coverage looks like? Or can someone help me better understand my insurance coverage? That's step 3 there. You know, can you direct me to, or are you aware of sources of financial assistance, manufacturer programs, Copayment Foundation programs, private assistance programs? If you need to appeal or ask for an exception, ask them, you know, how do I go about doing this? Sometimes even, hey doc, you know, I know we're going to prescribe this. I hope everything goes smoothly, but if I need to appeal, to whom do I reach out to in your office? And then finally, just ask them, you know, is there anything I missed? Is there anything I didn't ask you to understand how I get the right medication and coverage? I think that the point here is, you know, don't be afraid. Ask the difficult questions sometimes. And I think you'll find that most physicians are more than willing to either work with you or provide somebody within their practice or within perhaps their health system who can help you with that. So again, what I hope to have accomplished at this point is to giving you a little information about insurance coverage, about specialty pharmacies, about what goes on behind the scenes at specialty pharmacies, about some of the financial realities that you're facing now, and about how you need to work with your doctor in that shared process. So with that, Stuart, I think I ran a few minutes longer than I projected I would, but I'm sure we have plenty of time. So I'll turn the floor back to you, and we'll start the Q&A portion.
Well, I'm giving you a round of applause because I'm sure a lot of people were very happy with the content you provided. I mean, that was just, I don't know how people would have any questions after you spoke all about that, but yet we do have some. And before I get into the questions, a couple of people were asking me, who is SANDOZ? You know, what is it that they represent? They've never heard of a drug from SANDOZ. So I'm just going to let you all know that they are probably the new kids coming up on the block, and that they are the new kids coming up on the block. And they have a biosimilar that is not being discussed tonight. It's not part of the topics, but you will be hearing a lot about biosimilars in our upcoming programs. And we started discussing them in recent programs. And again, that's a medication that's not here yet, but will be here soon. And it's coming to a theater near you, okay? So you'll know about that soon. All right, next, we have a lot of questions. I'm going to take some from online. And we have a Cindy who's asking, how do we know or find out what doctors are on the committee for developing the formulary, that affects those of us with MS?
Cindy, you asked a great question, and in general, that is not a publicly available type of thing because these insurance carriers are privatized. Their P&T committees are generally not available for public information, but I can tell you the composition of those P&T committees. Typically, they will have 1 or 2 internal medical directors on the committee. They will have 1 or 2 internal pharmacists. They virtually all have 1 or 2 retail pharmacists from the community. In the case of MS drugs or cancer drugs, they'll have an MS specialist if it's an MS drug, or an oncology specialist or 2. Sometimes if it's a cancer drug, they'll often have a representative of your pharmacy benefit management group. Sometimes a member of an advocacy group sits on the committee. There are sometimes generalists like primary care physicians, internists, family practitioners, not so much in MS, pediatricians. So in general, I can tell you the composition of the committee, but there are literally hundreds, if not thousands, of P&T committees across the U.S. And because these are all private organizations, they don't make those members of their committees publicly available. Now, if CMS were to have a P&T committee, which they don't, because as you know, Medicare Part D is privatized, those committee members would be public knowledge, just like the committee members on the FDA committees are. But the reality is we can only tell you the general composition.
Okay, thank you very much. Judy asks a very good question, and that is, are there any benefit or is there any benefit to straight Medicare versus Medicare Advantage?
Well, it depends on your needs, Judy, and that is a decision, again, that needs to be a shared decision, not between you and your doctor, but between you and your spouse, significant other, family members, or if you have an insurance broker. Here's the reality. Medicare is not free, no matter where you get it. Medicare Part A is available to everyone over the age of 65. Medicare Part B is also available to everyone, but it has a premium. And as you know, if you're a Social Security beneficiary, either because you've aged in or because of disability, that Part B premium is deducted from your monthly stipend before you ever get it. And then Medicare Part D, or your prescription drug plan, has a premium. So you need to evaluate, okay, what's my out-of-pocket costs and what do the benefits look like that I'm getting under Medicare versus in Medicare Advantage, Parts A, B, and D are all rolled into one that are affectionately known as Part C. And Part C usually has a single premium that you pay to the Part C carrier because that's a private carrier. The government reimburses that private carrier for virtually all of the cost of your care, and they can actually lower your out-of-pocket costs compared to the individual premiums you may pay. But again, you have to look at it, because if that Medicare Advantage plan doesn't have your doctors in it, doesn't have your network of pharmacies in it, doesn't have your hospitals in it, while it may be a financially attractive package, it may not necessarily be the clinically attractive package. So it's really one of those things. It's a great exercise in shared decision making at a different level, really looking at all of those factors and making a decision. And I know it's bewildering, but also know that there are brokers out there that can assist you with that. And yes, they do take a small fee, but typically that small fee is paid for by the insurance carrier if they place you with that insurance carrier. Sometimes there are advocacy groups that can help you with that, and it depends on where you are, whether one of those advocacy groups, or sometimes you just simply may have a friend or a family member who can help you with that. So it's a very cogent question. It doesn't have a simple answer, but I hope I've given you a few of the things that you need to weigh as you make that decision. Do I take standard Medicare? And typically with standard Medicare, you also have to buy a supplemental coverage. So you have yet another premium, because as you know, Medicare Part B is an 80-20 plan. So if you just have standard Medicare Part B, you will pay 20% of everything that's paid for under Medicare. A lot of moving parts there, and I could probably spend an entire lecture. In fact, Stuart, I think we have a Medicare presentation coming up sometime later in the summer. So, stay tuned.
Well, and it's I don't have the date in front of me, but everybody will know about it that is on here tonight. Just remember to check your email. I mean, like I said earlier, we have a lot of programs coming up, and even all of our in-person programs are all being streamed out to you all. So it's not that you have to be there, but you should be there if it's happening in your area, because you can more easily get a question asked and answered. All right. Next, spinning off a little bit from what you were just talking about, for those that have to go on to Medicare due to illness prior to 65, there seem to be many limitations to which coverage they can actually get. And sometimes, where they have been told over and over and over again to get the Medicare, the straight version that you were just talking about, or something called Medicare supplement, versus an Advantage plan, sometimes they have to take the Advantage plan just based on the age restrictions that are going on in their area. Is that true or not?
It sounds interesting because if you're one of the 6 or 7% of Medicare beneficiaries who are now approved for Medicare benefits because of disability, the other group that gets approved under the age of 65 for Medicare are people who have been more than 30 months on chronic renal dialysis. My understanding, and perhaps I've misunderstood something, but I don't think so, is that once you get that eligibility from Medicare, you're entitled to Medicare Parts A and B. You will have to buy a separate Medicare Part D plan. But again, as I understand it, if you're a Medicare Part D plan, one of those private drug plans, anybody who is a Medicare beneficiary should be eligible for your coverage. I think somewhat conversely to where I heard the question, Medicare Advantage plans in your region may not be able to offer you all of the services and the network. So I would actually see somewhat of a differing viewpoint that the Medicare Advantage plans, which while they may be financially more advantageous for you, may not offer you some of the providers and services that you want. Again, and I'm not a lawyer, so my understanding is once Medicare has approved you to be a Medicare beneficiary, you're entitled to all of the benefits that you would otherwise get when you age into the process.
So firsthand knowledge was that there are certain companies whose names I don't remember the names of, but which you could not get until you turn 65.
That may be Medicare supplemental coverage. You may be right on that.
That's right.
Yeah.
That's right.
Yeah.
And or the premium for getting in was tremendously higher than if you were just at 65 or greater.
Understood, because their actuaries basically projected the cost that if you are getting Medicare because you're disabled or have ESRD, you already have a high cost medical condition and therefore rated the premium based on that. So, that makes a lot of sense, but that's Medicare supplement, which again is privatized, remember, not Medicare itself. And so that makes sense. But the Medicare Advantage plans, if you're in Medicare, they have to take you. You're absolutely right.
Okay, thank you for that. All right, next, prescription assistance for a person that's getting an MS medication directly from, or not directly, but even just say that they're using a product from Biogen. Again, I'm just using this as an example, all right?
Yeah, sure.
And but how come the prescription assistance from that pharmaceutical company cannot work with you unless you have private insurance versus government insurance, or such as Medicare or Medicaid?
That's a great question. And yes, you can get copayment assistance from manufacturers if you have private insurance, because there's nothing to prohibit that. But the federal statutes that created Medicare way back in 1966, in fact, we're coming up on the anniversary this Friday, July 1, 1966 is when Medicare went into effect. Those statutes, among other things, as they evolved over the years, created something in the law that prohibits inducements. And so therefore, if manufacturers pay copayment assistance directly to you or your drugstore on your behalf, that by the Department of Health and Human Services and by the Office of Inspector General is considered an inducement and therefore prohibited by federal law. So that's why you can't get it directly if you have Medicare. Now, what you can turn to are private foundations, things like Patient Assistance Network Foundation and others that receive unrestricted grants from pharmaceutical manufacturers, and you can apply for grants from them. There's good news, they exist, and there's several of them. I just mentioned one of them as an example. There's also bad news. These organizations depend on donations from large organizations like manufacturers, as well as donations from the public. So their funds are limited, and if they run out of donation money, you get put on a wait list for financial assistance. And therefore, even if theoretically that assistance is available, you may either not get it, or most of them have a maximum benefit that they can grant you, which may not be sufficient for your needs. So the reason why you can't get it if you're on Medicare is, simply put, it's against federal law.
Okay. You know, they've changed laws recently on certain things. I guess these can be changed too if you get enough people to say make a change, right?
That
Okay.
would probably require a bipartisan Congress that's unheard of these days, but I won't go on to that agenda.
Okay, exactly. All right. Next, with prior authorizations, people are asking, why is it that every 6 months it seems that they're having to get, their doctors have to do another prior authorization rather than it being a year as it had been in the past?
Yeah, again, another great question, because the reality is, if you've been on a medication for a year or two and you're on a stable dose and you're doing well, there really is no reason to reauthorize that more often than every year. And of course, you do have to reauthorize it every year because your plan benefit runs year to year. So as your new benefit starts on the heels of your old benefit, you have to reset the clock and reauthorize. My only caveat there, especially if you're in commercial insurance, is because much of commercial insurance, 60+% of commercial insurance, is self-funded by employers, which means the insurance company is ultimately not paying your bill. Your employer is paying the bill and paying the insurance company a fee to administer the benefit. Many employers are saying we want a better track and a closer monitoring of how these drugs are being dispensed and used. And sometimes at their request or at the request of their benefit consultants, those prior authorizations have been moved up to twice a year. And for some diseases, not typically MS, even more often. It doesn't seem fair, but it's the spinoff of the cold reality that drugs that MS patients are taking now are high 5 and sometimes even 6-figure drugs. And employers are feeling the pain, and I suspect it's only going to get worse if indeed we move into a recession or recession-like atmosphere.
Shh, don't say that. Okay.
Financial steward, it's all about the dollars right now.
I got it. All right, so say that again.
I said sadly, isn't it? But
sadly,
I guess if the cost of these treatments were at a different price point, things probably would look different, but that's not what it is. So we deal with the matter at hand.
We do. Thank you for that. Thank you for those answers. By the way, I do have several questions remaining, but for everybody that's online, I guess you want to stick with the questions that I have for the doctor, or you don't want to ask your own. I do have one from Susan, but other than that, if you have questions, ask them, all right? All right, Susan's asking, is there a reason why one can get patient assistance with brand name drugs for MS, for example, Ampera, but no assistance for a generic, even though the generic might be $400 to $500? Is there a way around this?
Well, again, think about where the assistance comes from. It comes from manufacturers of drugs, and brand name manufacturers have an exclusive license for that drug, and therefore, typically they can charge more for their drug. Generic manufacturers really don't have that exclusive license. They work on much smaller operating margins than brand name manufacturers. And quite literally, generic manufacturers don't contribute to copayment assistance programs. Now, that might change with biosimilars. We don't know yet. But because generic manufacturers don't put out money for copayment assistance, there just literally isn't any, because the source, which is the manufacturer, whether it's directly to the patient for commercial beneficiaries or to Medicare beneficiaries through foundations, those funds just don't exist.
Okay, thank you. Next question. Why is insurance now only covering the generic form of Tecfidera? And yeah, I think you just answered that, but it's not just Tecfidera. Again, it's the fingolimod, it's all the other ones as well. And so if you just want to repeat that again, this person will probably be happy.
Yeah, I can repeat that. I think the first thing we need to understand is, generics are not just bad carbon copies of a good piece of artwork. They literally contain the same chemical, the same molecules, and are manufactured under rigorous standards by the FDA. But because the generic manufacturers get into the game after the patent life, which means the exclusivity is over, they don't have any research and development costs. They simply have the manufacturing and distribution costs. They don't need to advertise their drugs or market their drugs. So they basically can produce the drugs at a fraction of the cost that the branded manufacturer can do when you consider all of the other expenses the branded manufacturer has, including research and development for new drugs. So because of that, their drug costs a fraction, often, tiny proportions of what the branded drug costs. And since it is exactly the same product with exactly the same indications, it's a much less costly alternative, not only for your health plan or your employer, but for you, because typically you have a much, much lower out-of-pocket cost. Don't be afraid of generics. 90% of all prescriptions dispensed by volume, by number in the United States are generic drugs. I personally take 3 generic drugs for minor chronic conditions. I have no fear of going to a generic, and it only makes sense financially, both for you and for the healthcare system.
Right. Well, but Susan is correct. I mean, if she's paying $0 for her prescription brand, okay, and then it becomes a generic and she has to pay $25 or $50 a month out of pocket for that because now it's not covered. So now it's costing her a great amount more than what it was costing when it was brand.
Yeah, and she does raise a good point, and it is one of the unavoidable consequences of drugs going generic if you were getting manufacturer assistance to cost you $0. However, if you weren't getting manufacturer assistance, you'd be paying a lot more than $0. So yes, those people who got manufacturer's assistance in the past are going to unfortunately get some negative consequences. But I don't foresee that changing, because of the differential in cost that the third party is paying, that is your payer or employer or government for those drugs.
So the downside again, though, to that is the person that was getting prescription assistance to begin with was getting prescription assistance because they could not afford to be paying whatever cost it would have been coming out of their pocket. And now, unfortunately, they're having to take that money out of pocket to pay.
That's true, Stuart. But if they were paying 20% of a $3,000 drug, that would be a lot more money than $50 on a $500 drug.
I got it.
Yeah.
All right. Next, Jim is asking, how long does a drug have the exclusive rights when entering a market?
Well, the period of exclusivity, I believe, and don't quote me on this because I'm not told, but it's about 17 years. But it's 17 years from when the drug patent is filed. And so if it takes quite a few years to get through development and clinical trials, when it hits the market, it's only got the remaining term. So you've seen drugs, come on the market and have 10, 11, 12 years of exclusivity. Other drugs, which had a much longer, more arduous development process, may only have 2, 3, 4, 5 years of exclusivity. So it sort of depends on how quickly that drug gets through the development process.
Okay, thank you. All right, next question is
when the drug hits the market. The clock starts when the drug is patented.
Okay, next question. How does MyRx work that pharmacists can access what I might be using from somewhere else?
Well, you have asked the Stump the Stars challenge. I am not knowledgeable on those external programs, and so I really can't answer the question about MyRx or GoodRx or any of those programs.
I think it has something to do with electronic records, though, would it not?
I don't know. I'm totally blinded to those.
Okay. All right. Next, how can an insurance company force you to change to a drug that you are having a reaction to, even if certified by the doctor that that drug is causing a reaction.
They can't. And that's when you have to appeal it, and you have to appeal it to whatever level it takes to do that. They just, I mean, if they're trying to do that, you have a great appeals case, and you ultimately will win that one. The problem is it takes patience.
That's right. Okay, next, what do we have? Again, can you mention where a person could get help with the cost of medications?
Well, certainly if you're commercially insured, you can turn to manufacturers. That is the source. If you are insured by Medicare, you do need to go to private foundations, like I say, Patient Assistance Foundation, Patient Network Foundation, National Organization of Rare Diseases. A lot of those organizations have assistance funds. My best way to tell you, you can do an internet search, but you may get frustrated with that. Most large practices now have financial counselors, or even your specialty pharmacy has a financial counselor. So if you're getting your drug through a specialty pharmacy, ask them to help you pursue those avenues of assistance. Remember that friend or foe. In that case, they can be your best friend.
Correct. All right. What are the Medicare D plan rules for specialty pharmacies?
I think there you're talking about, when a drug becomes specialty pharmacy and what your out-of-pocket cost is. In 2022, any drug that costs more than $820 per month can be considered a specialty pharmaceutical, and therefore distributed through specialty pharmacy and placed on one of those higher tiers, also known as the specialty tier, which means basically if your drug costs more than that per month, you could find your drug on a specialty tier, have that drug required to be distributed by a specialty pharmacy, and have to pay a co-insurance, which in Medicare can be a fairly high percentage. Remember, co-insurance is that variable percentage. I showed you a slide on that. And you may have to pay anywhere from 25 to 33% of the cost of your drug until you reach your out-of-pocket maximums, your benefit maximums, and even then you're going to be paying 5% of the cost of the drug. So it's really how that works in Med D.
All right. Last question. Do different Medicares have different formulary costs?
Yes, they do. And that's Medicare Part D. It all depends on your carrier, whether it be like a Humana, United, CVS, Caremark, Express Scripts, et cetera. They all have to have, they have to meet the requirements of CMS, but typically these plans now have what are called 5-tier formularies. They have a generic category. Sometimes they have 2 generic categories. They have a brand preferred category. They have a brand non-preferred category, and they now have specialty categories. They may have 1 or 2 of them, a brand or a specialty preferred, specialty non-preferred, and the out-of-pocket money typically goes up depending on the tier, but it can vary from plan to plan. Typically, your generic tier or tiers are the lowest cost ones, and they're a fixed copayment, often not much more than $5, $10, $20, where your specialty tiers are virtually all co-insurance tiers that can range anywhere from 23, the maximum co-insurance, even on a non-preferred tier under Medicare regulations is 33%. So look carefully at the different offerings in your area for Part D plans because they do have different formulary tier structures and out-of-pocket costs. Also, you can go online and at cms.gov and look at what these plans have to offer in terms of drugs that are on your formulary, and even search to see if the drug you need or take is on their formulary. So again, it's one of those, you have to do a little research or get somebody to help you with it.
Great. Thank you very much, Dr. Owens. Thank you for being with us. And for everybody to know, Dr. Owens will be back again with us next month at the end of the month to do part 2 of this program, which you all will see in your emails as we go forward. Okay. So again, everybody have a great night and be well, stay safe, and good night again. Bye-bye.
Good night. Thank you, Stuart. It's been a pleasure.